I think I am audible now. Am I audible now, guys? Please check now if I am I audible? Can anybody confirm that am I audible now? Yeah. So welcome to the Ophthalmology PYQ Inset session. I was saying that I think you must be fine and really preparing well for your Inset examination. And as you know that PYQs are important, but they are really very important for the Inset examination, as most of the times we are having a lot of PYQs. Many times they are repeated as such also, and many times they are coming as a similar questions. So they will be very high yield. Yes, ma'am. Okay. So thank you so much for the confirmation. Let's get started. So first of all, we will start with the INSET November 2022, the recent paper. So if you see the first question, topical atropine is contraindicated in. So they want to know that where you cannot give the atropine. So one is malignant glaucoma, second corneal ulcer, third is acute congestive glaucoma, and fourth is acute anterior uveitis. Now, as I always say that there are two ways of doing a question. First is the direct one and second is by eliminating. So I will tell you how to do both. One is your direct method. So let me tell you the answer. The answer is actually the acute congestive glaucoma. This is the direct answer. Why? Because you know that in the acute congestive glaucoma, it is this mid dilatation of the pupil which brings the attack. Of acute congestive glaucoma. We all know that it is the mid dilatation of the pupil, and obviously in the predisposed individuals, they will bring the attack of acute congestive glaucoma. Now, what are the predisposed individuals? That is another important thing. So we know the risk factors. What are the risk factors of the acute congestive glaucoma, right? So I'll try that meanwhile we are discussing a PYQ, we are discussing the options, we will try to do all the other important aspects of this question, how this question can be reformed, what are the other things that you need to know related to this question. Okay, so what are the risk factors of acute congestive glaucoma, right? So start writing the risk factors. Number one, obviously hereditary. So we can have the hereditary predisposition for the acute congestive glaucoma. Then it is more common in females, especially more than 50 years of age, and all those who have the shallow anterior chamber. For example, there can be hypermetropes. We can have the hypermetropes. Those people who are having the hypermetropia, they also have a high risk. Why? Because they also have a shallow anterior chamber. Then you must be remembering that I always tell you one very important thing, and that is the type A personality. Type A personality. So these people also have a risk of a lot of diseases, not only the acute congestive glaucoma, the diabetes, hypertension, thyrotoxicosis, peptic ulcers, CSR. We have so many things. Okay. So what are these people who have three things in common? Hurry, then we have worry, and third is a curry. Hurry, worry, and curry. So all those people who are always in worry, always in hurry, and taking a lot of curry. So these are type A people and they have more risk. Now, what are the other characteristics of hypermetropes? So you can get small eyeball, we can get small eyes, we can get small corneas, and then we can have the shallow anterior chamber. So any person who is having the risk factors and he goes into the mid dilatation of the pupil, he is suffering from acute congestive glaucoma attack. So obviously you are not going to give the atropine in these people. Now let us try to see the other things. Number one is malignant glaucoma. Now if you see the malignant glaucoma is also called as, what are the other names? The malignant glaucoma is also called as ciliary block glaucoma, or it is also called as the inverse glaucoma. This is also called as the inverse glaucoma. So because this malignant glaucoma or the ciliary block glaucoma is often treated by mydriatics and cycloplegics as a treatment of choice, because what is most important? You have to open the ciliolenticular block. What is this block? Due to the misdirection of the, it occurs due to the misdirection of the ciliary processes. This is occurring due to the misdirection of the ciliary processes, and they are turned backwards. Due to this backward tilting of the ciliary processes, the aqueous humor is also going backwards. It is accumulating in the vitreous cavity. So what we have to do, we have to open this block, ciliolenticular block, that is opened by the mydriatics and cycloplegics. So obviously it is not contraindicated. It's a drug of choice rather. Corneal ulcers. In the corneal ulcers, we are using the mydriatics and cycloplegics as the adjuvants. So this is again a very important point also, and many times this has been asked as a PYQ that mydriatics and cycloplegics are used in the corneal ulcers for. So this is for the giving the pain relief, because whenever we have corneal ulcers, we have some amount of acute anterior uveitis, we have some amount of iridocyclitis, and you know what is the treatment of choice of acute anterior uveitis, which is given as a separate option also, that is the mydriatics and cycloplegics only. So whenever we have corneal ulcer who is having the associated acute anterior uveitis, there also we will give mydriatics and cycloplegics. So both by direct as well as by elimination, you come to know that the answer will be acute congestive glaucoma. All right. Good evening everyone. Okay, now coming to the next question. Angle subtended by 6x6 letter in the Snellen's chart from the 6 meters. I think you cannot get a simpler question from the Snellen's chart at least. So we have done this in the class also so many times. What we learned, this was the Snellen's chart. Okay. So what is the distance at which this patient is standing? The distance at which the patient stands, distance is actually 6 meters, and the patient has to read these lines. So topmost letter, the next one, the next one, the next one. Okay. So when the patient is reading topmost, the topmost letter if the patient is reading, then it is 6/60. Okay. And from 6/60, it will be 6/36. Then it is 6/24, 6/18, 6/12, 6/9, and finally it is 6/6. Yes or no? So what is common here? Common is this 6. So what is this 6? What does this 6 mean? This 6 means the distance. It is the distance of the patient from the chart. Okay. The distance of the patient from the chart is actually 6 meters. And what is the meaning of this 60? The distance at which the normal person can read this letter. Okay. So normal person can read this letter from 60 meters, but the patient is reading from 6 meters. Similarly, 6/36 means what? A normal person is reading it from 36 meters, but this person is reading it from 6 meters, right? So they have asked you a question based on the minimum angle of resolution, right? So what was the concept? The minimum angle of resolution. So always remember for this that each letter, it is each letter of the Snellen's chart. Okay. If you remember this line, you will never get wrong in these questions. Each letter of the Snellen's chart subtends. It will subtend the angle of 5 minutes of the arc. Okay. All will make 5 minutes of the arc, but at the respective distances. Okay. Now always remember that what are their respective distances. Just now we have talked about them. This is 60 meters, 36, 24, 18, 12, 9 and 6. These are the respective distances. So that means this 6/60 will make 5 minutes at 60 meters. This will make at 36 meters. This will make at 24 meters. This will make at 18 meters. This will make at 12 meters. This will make at 9 meters. And so this will make at 6 meters. So basically they have asked you the most simple one. Very good, Shri. You are absolutely correct. It is the 5 minutes of the arc at the respective distance. So this is 6 by 6, which will make, so they are asking you about 6 by 6 letter only. That means respective distance is 6 meters and they are asking you at 6 meters only. So what should be the answer? Therefore, the answer is the 5 minutes. Now, suppose if I change from 6 by 6 to 6 by 60, who will answer now? Suppose I change this letter, and don't use the pen and paper. Do it orally, because in exam also you have to do it orally. Okay. So what happens? We know that as we go closer and closer to the letter, the angle will go on increasing. We are going close. So angle will increase. Suppose this is the letter E here. So if I am going closer to this letter, the angle size will go on increasing. So you have to see how much the person is going closer. From 60 meters to 6 meters. So he is going closer by 10 times. So just multiply this angle by 10 times. 5 into 10, 50 minutes. Exactly. Very good. Debubam, Yamali, Shiva, Shri, everybody has given the right answer. Then the answer will be 50 minutes. So similarly, from 36 to 6. So it is 6 times. 6 into 5, 30 minutes. 24 meters. So 24 to 6. It is 4 times. So 5 into 4, 20 minutes. If I talk about 6 by 18. So from 18 meters, he is going to 6 meters 3 times. 5 into 3, 15 minutes. This is how you can do any question of the Snellen's chart. What is the minimum angle of resolution? What is the meaning of the visual acuity? Achha, one more thing also. If they ask you what kind of visual acuity do you get in Snellen's chart, it is the minimum resolvable. It is minimum resolvable visual acuity. This visual acuity is called as the minimum resolvable visual acuity. Okay, because it depends upon the minimum angle of resolution. Therefore, it is called as minimum resolvable visual acuity. All right. All right. Now coming to the next question. Okay, a very simple one. What is the most common cause of blindness? Most common cause of blindness according to 2015-2016 survey. So guys, if they ask you about blindness, always remember it will be cataract. Okay. Now, what about the other things? This we have read in cases of the community ophthalmology. In the community of Ophthalmology, we have read this. Okay. Why I'm telling you this? So that you do not take much time to revise your notes if you want to go back to your notes. So in your notes, in the community ophthalmology portion, you have written all this. Okay. So if you see this, uncorrected refractive error will be the most common cause of the low vision. There is a difference between the low vision and the blindness. Most common cause of low vision is the uncorrected refractive error. Most common cause of blindness is the cataract. Okay. And most common cause of the blindness in children in India, that is vitamin A deficiency. Now always remember, every year we get at least one question on vitamin A deficiency. So try to realize the high topics. You are going to get a question on vitamin A deficiency. You are going to get a question on the visual acuity. You are going to get a question on the acute red eye. So there are certain topics which are all-time favorites, and you have to actually recognize and highlight these topics in your notes, and you have to read them. Okay. Then trachoma is again important. Why trachoma is important? Because it is the most common infection causing blindness in India. So now you have to also remember that previously when I talk about the Vision 2020 program, previously glaucoma was not there, but now even glaucoma has been added to the Vision 2020 program. Like cataract was there, refractive errors was there, we were having vitamin A deficiency, trachoma and the onchocerciasis, but now even glaucoma has been added here. Okay. So a direct question, but very, very high. There are so many things they can ask for, because they are always asking one community ophthalmology related question of all the subjects. So that is why also vitamin A deficiency is important, trachoma is important, cataract steps of the surgery are important, something like this. Okay. Yes, safe strategy. Exactly. Okay. Now coming to the next question, not true in the complicated cataract. Not true in complicated cataract. Breadcrumb appearance, we have. Can it be seen after uveitis? Yes. Krukenberg spindles? No. Where do you get the Krukenberg spindles? Quickly comment on the live chat. Where do you get the Krukenberg spindles? And then we have the polychromatic luster. So we have studied this in the cataract, and in the other types of acquired cataract, we have studied about the complicated cataract. Exactly, it is the. But where do you get them then? You people are exactly correct. Krukenberg spindles is the answer. But where do we get them? Like complicated cataract means which is occurring as a complication. As a complication of the ocular diseases. As a complication of the ocular diseases, and the most common one is the chronic anterior uveitis. The most common is the chronic anterior uveitis. Then number 2, we can also have the high myopia. We can also have the high myopia. Then retinitis pigmentosa, long-standing retinal detachment. Long-standing retinal detachment and the intraocular tumors. And I told you there are 2 important features. See these. These are the things. One is the polychromatic luster. This is the polychromatic luster. You can see. This one is the polychromatic luster that you can get here. And yes, and what is this, guys? Breadcrumb appearance is the granular consistency that you are getting on the slit lamp. Now you have to tell me 2 things. Where do you get the Krukenberg spindles? And second thing, what is the cataract which is occurring in this complicated cataract? What is the fancy name of it? What is the fancy name? There are 2 things. One, where do you get the Krukenberg spindles? So you can see these are the Krukenberg spindles. What is this? You can see these are small pigments. So these are the pigments on the corneal endothelium. These are the pigments on the corneal endothelium, and because they are pigments, so now you can remember its cause. It will be pigmentary glaucoma. Therefore, this is the pigmentary glaucoma. And what is the name? What is the name of the cataract, and what is the morphology of the cataract? So remember, the name of this cataract is the rainbow cataract because of the polychromatic luster. And I have shown you the picture also so that you do not have any confusion. See this. This is the polychromatic luster that you are getting. And can you see the morphology? Now looking at this picture, can you tell me what will be the morphology of this cataract? Yes, it is the pigments on the posterior surface of the cornea. Then Krukenberg spindles are present in the pigmentary glaucoma. What is the morphology? Third important thing will be what is the morphology of this type of cataract. So always remember, it is the posterior subcapsular cataract. It is the posterior subcapsular cataract. You can see the location also. See, this is the cornea. I told you how to read the slit lamp image. Posterior polar nahi hai, it is posterior subcapsular. Now another question, what is the typical appearance of posterior polar? What is the typical appearance of posterior polar? Now this is cornea, this is lens. You are seeing in the center with the polychromatic luster. So it has to be posterior subcapsular because posterior polar, if I am talking about the posterior polar cataract, this will give me the onion ring appearance. This will give me the typical onion ring appearance, posterior polar cataract. Yes? Did you get this now? Yes, you can call it as cupuliform or you can call it as posterior subcapsular cataract. Now, an important thing for you people. What are the causes of posterior subcapsular cataract? I got a BSc. So you can easily remember the causes of posterior subcapsular cataract with the help of this mnemonic. I for the ionizing radiations. I for ionizing radiation. So radiational cataract is posterior subcapsular cataract. G for glass blowers. G for glass blowers cataract, which is caused by the IR rays, infrared radiations. A for atopic. Atopic cataract. What is the other name of the atopic cataract? What is the other name of atopic cataract, guys? You have to tell me this. Then B for busulfan. B for busulfan is there. Then S for steroids. Steroids are also causing posterior subcapsular. And C for chloroquine. C for chloroquine. C for complicated cataract. C for complicated cataract. And we also, yes, very good. It is the shield cataract. Atopic cataract is also called as shield cataract. And apart from this complicated cataract, C for Christmas tree cataract also. All the fancy names. Christmas tree cataract. All these are the fancy names of the cataract and also which are causing the posterior subcapsular cataract. Right? So all the important details with respect to this question we have done. Now see this. Another important thing is that I have seen that AIMS people, like INSET people, they are always asking you the question over the corneal ulcer. Always. And mostly they are asking you about fungal corneal ulcer. So you should be very, very clear to find out the differences between the bacterial and fungal ulcers. Okay. A patient with a foreign body, with pain, photophobia. Now they have actually tried to confuse you also with the itching. Now ideally the word itching should not be used here. I do not know if it is a recall mistake or it was actually there, itching, because ideally itching should not be given here. Itching is word that is used for the allergic conjunctivitis or allergic keratitis. So they should not have used this word, and they have given you the history of fishtail trauma. So fishtail trauma means they have given you the vegetative trauma. So whenever they have given you the history of vegetative trauma, it's very, very clear that it's a fungal corneal ulcer. It's a fungal corneal ulcer. So basically, it is more important to identify whether it's a bacterial ulcer or whether it's a fungal ulcer. Now, once you know that it's a bacterial ulcer, you can easily tell the characteristics, you can easily tell the treatment. Once you know it's a fungal ulcer, again you can easily tell the characteristics, but the thing is identification. Okay, so one very, very important thing is whenever they are giving you history of trauma with the vegetative matter, it becomes very simple that it's a case of fungal corneal ulcer. Now even simpler from this is that they haven't asked you that which ulcer is it, they are just asking you the sign. So what can you see? So this is but obvious. This is hypopyon, because what you can see is the pus. It is the pus in the anterior chamber. It is the pus in the anterior chamber. So we can have hyphema, aqueous flare, hypopyon, or whatever. So you have to know what are the differences. When I say it is hyphema, when I say it's a hyphema, it is actually the blood. It is the blood in the anterior chamber. When I say it's a hypopyon, that means it is the pus in the anterior chamber, right? Now, what is the difference when hypopyon is due to bacterial ulcer and when it is due to fungal ulcer? So we will try to understand. When it is bacterial hypopyon, then bacterial hypopyon will always be sterile and always be mobile. While if it is a fungal one, if it is a fungal corneal ulcer, then the fungal hypopyons, they are always non-sterile as well as non-mobile. Non-sterile and non-mobile. So once you know, this will again help you in differentiation. Then always remember that in cases of fungal, the signs are always more than the symptoms. They are always more than the symptoms. So when you are getting a lot of signs, especially what are the signs of fungal corneal ulcer? Again, very, very important. Usually one or two signs are always given in the question, like it will be grayish, or it will be dry looking. It will be having the raised margins. It will be having the raised margins. Then we will have the feathery margins. F for fungal, F for feathery margins we can have. Then F for finger-like extensions. Very good. We can also have the finger-like extensions. That can also be there. And due to these extensions, we can have multiple small lesions. That will be called as the satellite lesions. This will be called as the satellite lesions. They are dry looking, grayish with the raised margins, with the feathery raised edges, with the feathery margins, with the rolled out margins, finger-like extensions, satellite lesions, and immune ring of demarcation. We can also have the immune ring of the demarcation that can be there. And what is the name? What is the typical name of this immune ring? This is called as the Wesley's ring. Immune ring of demarcation, that is called as the Wesley's ring, along with the hypopyon. So I told you the two characteristic features, and usually hypopyon is a big hypopyon. We do not have vascularization, and that is why the risk of perforation is also rare. Now, one important thing, I have written here that signs are more than the symptoms, right? Is one shot revision sufficient for INSET? Yes, exactly. See, high yield topics remain same whether it's a NEET or whether it's INSET. Only the way of asking of the question is different. So you have to understand that your important topics remains the same. So please go through it, and they are very high yield before your INSET also. Please read all the and go through all the one-shot sessions as well as their PDFs. Okay. All right. So I was saying that I am saying that signs are more than the symptoms, but don't misinterpret that we cannot have symptom in the fungal. We can have symptoms in the fungal, but signs are always most prominent. So don't just rule out fungal corneal ulcer on the edge that pain is written in the question. You can have pain, but pain is not the most prominent thing that occurs in the fungal corneal ulcer. Rather, it's the signs which are more prominent, and we can also have pain in the fungal corneal ulcer due to the added secondary bacterial infections. So be very clear. First, see the signs. If you are having these signs and uske saath, I am saying pain is also there. You cannot rule out fungal corneal ulcer by pain, because you cannot have all these things in the bacterial ulcer. So please first rule out the other options also, look at the other signs also, and then take the decision. All right. Okay. So we have done with this. Now coming to the next question. So again, important topic. I would say this is again an important topic for the INSET, as every year we are getting a question from the anti-glaucoma drugs. So we know that whenever there is glaucoma, see, a simple concept, if I have glaucoma, there are only two ways. Either there can be more aqueous formation. Either I can have more formation or I can have less outflow, right? So that means when I am giving the drugs to reduce the intraocular pressure, they can also work by two methods. Either they will decrease this aqueous formation or they will increase this aqueous outflow. Very clear. Now we will talk about the mechanism of action of the different anti-glaucoma drugs, right? So though everything about the anti-glaucoma drugs is important, okay, so whichever question is coming from whichever topic, like this question is from anti-glaucoma drugs, so you have to read whole of the anti-glaucoma drugs, okay. So it's of the aspect also, pharma aspect also, but because this question is on mechanism of action, so I am going to discuss all the mechanism of actions. So see here, decreased aqueous formation. So decreased aqueous formation, like one is your example is the beta blockers. Beta blockers are acting on the beta receptors which are responsible for the aqueous formation. So obviously they will decrease the aqueous formation. Then number two, we also have the carbonic anhydrase inhibitors. Carbonic anhydrase inhibitors are acting on this enzyme carbonic anhydrase, which is responsible for aqueous formation. So they are also going to decrease the aqueous formation. Now if I talk about the alpha adrenergic analogs, okay, if I talk about the alpha adrenergic analogs, so always remember that they have the double mechanism of action or dual mechanism of action. So they are decreasing the aqueous formation, and plus they are also increasing the aqueous outflow. Okay, now if you talk about the two different drugs, one is from selective and one is your non-selective. So we have got two kind of drugs here. We have got epra-clonidine and we also have the what you call as the brimonidine. So if you talk about these two drugs, both of them are having the property of decreasing the aqueous formation. Both of them are increasing the aqueous outflow. Like A for is epra-clonidine and B is your brimonidine. And always remember this thing that brimonidine is otherwise also very, very important drug. Now, always remember the mnemonic AT and then we have got BUS, bus. Okay? So, basically, it is this epra-clonidine which is increasing the trabecular. AT, T for trabecular, while US is uveoscleral. So, this is increasing the uveoscleral. This is increasing your uveoscleral outflow. And don't miss anything about this brimonidine. Very, very important. This brimonidine is useful as a neuroprotector drug. It is very, very important. It is the only anti-glaucoma drug which is giving you neuroprotection. It is also a CNS depressant. And you will get that if you go even back, go to the AIMS PYQ, you will get many questions that it's a CNS depressant. So which drug causes the apnea or which drug causes the drowsiness? It's very, very important. Which drug is contraindicated in the infant? So in all these conditions, your answer will be the brimonidine. Answer will be the brimonidine only. Now talking about the next, that was your hyperosmotic agents. So if I talk about the hyperosmotic agents, obviously these drugs are, acting by decreasing the vitreous volume. So they are not decreasing the aqueous formation or they are not increasing the aqueous outflow. So answer is not this also. And finally, we have got what you called as the Rho kinase inhibitors. Finally, Rho kinase inhibitors. So in this Rho kinase inhibitors, who will tell me the example of Rho kinase inhibitors? Anybody? What is the example of Rho kinase inhibitor? They have got three mechanisms of action. So whenever you do not get any drug which is acting by any of the actions and this is given, so answer will be this only because we have got all three mechanisms of action. They are decreasing the aqueous formation and they are increasing the trabecular outflow. That will be your answer, and decreasing the episcleral venous pressure. Yes, very good. It is nitarsudil. And anybody who can tell the side effect of nitarsudil? Side effect of nitarsudil? What is the side effect of nitarsudil? So if you look at the question, which of the following drugs is acting by increasing the trabecular outflow? Timolol is a beta blocker, so this will decrease the aqueous formation, right? Then acetazolamide is a carbonic anhydrase inhibitor. This will also decrease the aqueous formation. Brimonidine is a bus, uveoscleral. Therefore, answer is the nitarsudil. Very good, Kamran. So, the side effect here is the vortex keratopathy. Yes, you are also correct. Vortex, everybody has given the right answer. Very good. It is the vortex keratopathy, or it is also called as the cornea verticillata. Vortex keratopathy or the cornea verticillata. Right? So, all the anti-glaucoma drugs done. Now, this is a typical inset type of a question where they are asking you match the column. So, come on, you people will help me in doing this. Ishihara's color. Oh, I have given you the answer. So, Ishi, can you take the central vision and IOP ke liye we have to take the Goldman's applanation tonometer. So, it is 2 here, then 1 here. And for the peripheral vision, peri. I always tell you in the class also it's peri and peri. So for this, it is actually 3. This is 3. So obviously what is left here is the 4. So we have 1A1. We have got A1. Then we have got B4, C2, and we have got the D3. Yes. So answer is A. Therefore the answer is A. Now let us see these things. You can see these are your Ishihara's color plates, where basically we are trying to test that whether this patient is able to recognize the contrast between the two colors. So we have red color base, and then over that some pattern will be made from green color, or it can be vice versa also. We can ask the patient to read the letters. We can ask the patient to follow that particular pattern. This is there. So can you read this? What is this? Conjunctival hyperemia. What is this? Means in what respect you are saying? I do not know. What is this digits written? Can you please read this? What is this written? Anybody? These are the Ishihara color plates, and let us see if you can read this. See this. What is written here? See this and answer it. Yes. Very good. Very good. Yes. It is actually this 12. Yes. Right. Now see this also. We have seen this one. What is this? What is this? This is the Goldman's applanation tonometer. And Goldman is the gold standard. Gold for gold. You have to remember Goldman's applanation tonometer. And then we have got the different kind of perimeters. These are the different kind of perimeters. So if you remember, for the visual field charting, we are using them. We can have the central visual field, and then we can have the peripheral. And then we can have the peripheral visual field. Central will be from 0 to 30 degree. And peripheral will be beyond 30 degree. It will be beyond 30 degree. So C for central and C for campimeter. And peripheral ke liye we have got the perimeter. These are the different instruments for the visual field charting. So C for central, C for campimetry, and peri. That means peripheral ke liye we have perimeter, right? Gold standard is the Goldman's applanation tonometer for the IOP, and then this is your screen, tangent screen, which is used for the central fixation also. So we can use that central screens, tangent screens we can use for the central vision. Then we can use different kind of perimeters for the peripheral vision, Ishihara's plates for the color vision, and the IOP ke liye we have tonometers, right? So this question done, right? All right. So again a simple question. Most common cause of conjunctivitis. It's not most common cause, most common type. Most common type of the conjunctivitis in the COVID-19. So this is your acute follicular conjunctivitis. Acute follicular. Now see, COVID is again, this is occurring from a coronavirus, you know, and viral conjunctivitis may always remember that whenever we are talking about the viral conjunctivitis, it is always most common is the acute follicular. Most common type of conjunctivitis is always acute follicular conjunctivitis. No, it's not B. This will be most severe complication. This is the most severe complication of the COVID-19 in eye. Okay. So there is always a difference between most common and the most severe, and this is a very common dictum that I always tell you in the classes, that most common and most severe are never the same. So if they ask you the most severe complication of the coronavirus in the eye, then because orbital mucormycosis is associated with it, then the answer will be on mucormycosis. But if they ask you the most common, then it's acute follicular conjunctivitis. And these follicles are present where? So always remember, follicles are always present in the adenoid layer. How many layers are there in conjunctiva? How many layers are there? We have got actually the 3 layers. One is the epithelium. Then we have the adenoid layer, and then we have the fibrous layer. So we have got 3 layers, and all 3 have different specialities. The type of epithelium, adenoid may we have follicles, and along with the adenoid and fibrous, they together are called as the substantia propria. This is called as the substantia propria, and in substantia propria you are going to get the degenerations. We are going to get the degenerations. All right. Now coming to the next question, this lady, pregnant lady, is coming with a unilateral headache with a very important thing, that is pulsatile. Proctosis is also there, diplopia is there, tinnitus is there, but fundus is normal. Explain the other options other than the answers. Ankur, I think you have missed that part. I have just now told you that the mucormycosis is the most severe. It is not the most common, and uveitis is of course not the most common, or neither it's most severe, not it is the most common thing. If you look at the orbital mucormycosis, how it is occurring, this was going through the nasal route. So it was affecting your oral part, nasal part, it is affecting the respiratory tract and all. Then it's not basically responsible for the uveitis. So basically it's going to the apex of the orbit. And from the apex of the orbit, it will affect that origin of all the extraocular muscles. So we can have ophthalmoplegia, we can have diplopias, we have congestions, we have got necrosis, that is very important of the mucormycosis. And I could not get the 4th option. I think it must be something else. I do not know what they have given me, the same 4 options, right? Now see this. Now whenever you get a question on pulsatile proptosis. See, I know that everybody of you can do this question if you start from the basic sciences also, but that is always a longer route. Okay, so it's always easier to find out what is it, what is the diagnosis when you go clinically, and then you can follow retrograde to the basic sciences. So if there is pulsatile proptosis, word pulsatile proptosis is there in the question, then 99.99% of the times it is actually the keratoconus. Then it is the keratoconus fistula. Okay? Because no other place you are going to get pulsatile proptosis at your level. So for your scope, if there is pulsatile proptosis in the question, you should be clear that it is keratoconus fistula. Now, once you know that it is a CCF, you should know what is the meaning of it. This is actually a fistula or the opening. So this is actually the opening between the internal carotid artery and the cavernous sinus, right? So that means these two things are obviously involved, because fistula means fistula between the, it is a keratoconus. So internal carotid artery and the cavernous sinus. Now internal carotid artery has its branches, nothing else. So what are the other things that can be involved is by the cavernous sinus. So let's go to the anatomy of cavernous sinus now, and let us see what are the things or the structures passing through it. So what are the structures which are passing through the center of cavernous sinus, and what are the structures which are passing through the lateral wall of the cavernous sinus? Through the center, we have internal carotid artery and the 6th nerve, and through the lateral wall, we have got 3rd nerve, 4th nerve, and the 5th nerve, right? So that means all these structures can also be involved. Now, if you look at the question, what they have said that, they have said cavernous sinus, obviously it is involved. 6, which is in the center of cavernous sinus, internal carotid artery, yes, and 3rd nerve is in the lateral wall. So obviously, therefore, all the options are correct. So if they ask you what is the first structure to be involved, first structure to be involved is the sixth nerve. And because it is the sixth nerve that is involved, therefore we first get the diplopia in the lateral gaze. Because sixth nerve actually supplies the lateral rectus, LR6. So that is why the person will first get the diplopia in the lateral gaze. But they are not saying first. They are saying which of the following structures can be involved. So all the structures can be involved. So please read the question also very, very carefully. Okay. Next question. What is true about optic neuritis? So I think if you read the first option, you will be tempted to leave the other options. You even won't try to read the other options. But even if you are tempted, please read the options. So the answer will be same only. Optic neuritis, may the thing which is eternal truth is a RAPD. This is one of the earliest manifestations, first sign that you get in the optic neuritis. That is actually the RAPD, because it's a afferent pupillary defect. You know that the optic nerve is the afferent nerve in cases of pupillary reflexes. In cases of the pupillary reflexes, it's a afferent nerve. Therefore, it is true. Now, so answer will be A. Now, let us look at the other options also. They are saying multiple myeloma is the cause. So, we know multiple myeloma is not the cause. The most common cause is multiple sclerosis. The most common cause of optic neuritis will be the multiple sclerosis, and multiple sclerosis is a demyelinating disease. This is a demyelinating disease, and demyelination means decreased velocity. That is why we will get the abnormal visual evoked response. Abnormal visual evoked response. And what we are going to get here? We are going to get decrease amplitude and the prolonged latency. Decreased amplitude and prolonged latency we are going to get in these cases. Now, then they are saying that oral steroids are the drug of choice. So this is also wrong. And investigation of choice is CRCT. This is also wrong. It is the MRI which is the investigation of choice. And how can we treat this condition? When we go for the treatment, we always start with the IV steroids. We always start with the IV steroids, and IV steroids are actually given for 3 days. We give it for 3 days and then we switch the patient to oral steroids. This is given for 11 days. And then we have to taper these drugs. Taper in the next 3 days. So we have got total 17 days treatment that we are giving. And of course, it's not the oral steroids which are the drug of choice. It is the IV steroids which are the drug of choice. All right. Next question, not seen in the keratoconus. So, can you tell me the answer? Now, again, you can tell this question either directly or by elimination also. So, we have, we have Harp's tria, we have Munson sign, we have scissors reflex on the retinoscopy, and we have irregular astigmatism. Now, when I talk about the keratoconus, that means instead of this kind of a cornea, we are going to have this kind of a cornea. We have got the conical protrusion of the cornea. Now, due to this conical protrusion, you will have irregular surface. So, this person is going to have irregular surface, due to which we can have the irregular astigmatism. We are also going to have the increased axial length. We are also going to have the increased axial length, and due to which we can have the myopia. So if I talk about the refractive status of this patient, there will be irregular surface leading to irregular astigmatism. Irregular astigmatism can lead to this scissors reflex on the retinoscopy. Now, if I talk about the Munson sign, what is the Munson sign? Now, if this patient who is having keratoconus starts looking in the downward gaze, so what will happen? In the downward gaze, these apices of the cones will lead to the bulging of the lower eyelids, something like this, because there is a apices of the cornea. So these apices are actually leading to the bulging of the lower eyelid when the person is looking in the downward gaze. So this is called as the Munson sign. So Munson sign is also seen, scissors reflex is also seen, irregular astigmatism is also seen. That is why the answer is A, that is harp stria. Now directly also you know that harp stria are found where? In your very favorite bablu. So harp stria are found in the bablu, that is your blue baby boy. And what were the harp stria? Now always remember there are two types of stria. Okay, we have got two kind of stria. One is this one. You can see here these striations are actually horizontal striations. So H for horizontal and H for harp. These are the harp stria, H for horizontal and H for harp. And then look at the vertical also. See this. This is your vertical stria. V for vertical and V for what? V for vertical and V for what? So these vertical striations are found in keratoconus. Not only you should know which stria are found here, you should also know harp stria are found where and which are horizontal and which are vertical. Then look at this Munson sign. I told you now, when the patient looks in the downward gaze, there is localized bulging. There is a localized bulging of the lower eyelid when the patient looks in the downward direction. This is actually called as the Munson sign, right? So all the signs are clear and whole of the keratoconus is important. The difference between the horizontal stria and the vertical stria is clear. The horizontal stria are called as the harp stria, while the walk stria are called as the vertical stria. And where do you get the harp stria and where do you get the walk stria? That is also very clear, right? Now see this. It was an image-based question on the teresium. What is the incorrect statement about this? So the statements are: simple excision can reduce the recurrence by 90 to 95%. Consists of head, neck and body, progressive and regressive types. So teresium can be of both types, progressive or regressive, and it is having a elastonic type of degeneration. Now see, there are two kind of degenerations. Let us first discuss the two kind of degenerations that you get in eye. So conjunctiva degenerations, I told you that whenever we get degenerations, they are always present in the substantia. They are always present in the substantia propria. And we have got two things. One is the pingicula and one is the teresium. Pingicula is just the discoloration. This is just a discoloration, while teresium is a growth. Okay. So you can see this is a discoloration and this is a growth, you can see. So basically you can see that this is a teresium, right? So this is a teresium, and because it's a growth, therefore it will be symptomatic. While discoloration, though it was also a type of degeneration, but usually it will not cause any symptoms and it is asymptomatic. We are not giving any treatment. But teresium is a growth and it has got three parts. You can see this portion is a head or a apex. Then we can have neck portion, we can have body portion, and even the tail portion can be there. So it can even grow. It can go up to this limbus, it can go to this pupillary margin, and afterwards even it can cross this pupillary margin also. So slowly and gradually we can have much more symptoms. It can start just with the itching part, we can have watering, we can have redness. These are the simple things, because something which is foreign, outside growth, is going inside the eye. We will have itching also, watering also, redness also. Now what if it is going beyond limbus? It will start pressing the cornea. So at that time we will start having the astigmatism. Guys, who will tell me what is the kind of astigmatism found in teresium? What is the kind of astigmatism found in teresium? Question for you. And afterwards it can even block this pupil. So we can also have the obstruction. We can have the obstruction of the pupillary axis. So that can also lead to diminution of vision. Now every teresium will press the cornea, But every teresium will not cause the obstruction of pupillary axis. That is why the most common will always remain the astigmatism. And what is the type of astigmatism? Yes, very good. It is actually with the rule. It is with the rule astigmatism that it is causing. Now, if you see, two options we have already ruled out. So this is also correct that it is having the elastotic type of degeneration. It consists of head, neck and body. Okay? Now, can it be progressive and regressive? Yes. Why? See, when we talk about the teresium, it is having a growth. So growth may we are having two type of changes. One is the degenerative changes, while the pingicula was just having the degeneration only. This is having the degenerative changes, and this is also having the hyperplastic changes. Degenerative changes and the hyperplastic changes. Now you have to see which one is more. If I am having degenerative changes more than the hyperplastic changes, this will be the regressive type, right? And if I am having hyperplastic changes more than degenerations, then we will say it's a aggressive type. Then I will say that it's a aggressive type of teresium. So that means this is also true. This statement is also true. Okay. So if you see, this is also true. Therefore, answer to this question is A. Simple excision can reduce the recurrence by 90 to 95%. Simple excision can reduce this recurrence. Now, why this is wrong? Because a simple thing is that when we are doing the simple surgical excision, okay, then there is a chance of recurrence, and these chances of recurrence are about 30 to 80%. These chances of recurrence are about 30 to 80%. So it is other way around. They are saying it is reducing the percentage of recurrence by 90 to 95%, but it is actually the opposite of it. There are chances of recurrence in about up to 80% of cases. That is why answer is A. Okay. All right. So we have done with the November 2022. Now coming to the May 2022. If there is any doubt, you can post it on the group. Sorry, post it on the live chat. Okay. So which of the following is seen in the acute congestive glaucoma? Simple question. Which triad? You can see they have given you 4 triads. The Watts triad, Virchow's triad, Gotcher's triad, and Hutchison triad. So which triad is seen in acute congestive glaucoma? It is actually the Watts triad. And what do you find in the Watts triad? We have got the glaucoma flecans. We have the glaucoma flecans, which is the anterior subcapsular cataract. Then we also get the iris atrophy. Patches of iris atrophy are also there. And number 3, we have the pigments. We also have pigments on the corneal endothelium. We also have the pigments on the corneal endothelium. So always remember, we have the Watts triad in cases of acute congestive glaucoma, and it consists of anterior subcapsular cataract. We have patches of iris atrophy and also pigments in the corneal endothelium, right? Now coming to the next question, the patient presents with the incomplete closure of the right eye. Patient is not able to close his right eye. And we know that for the closure, which muscle is required? Orbicularis oculi. So we have seen that this muscle has been affected, and also cornea has decreased sensations. So which of the following is likely to be associated? So can you tell me any disease which is affecting the muscles also, which is affecting the trigeminal nerve also, so that we have got the decreased corneal sensation? And that is why it is none other than Mycobacterium leprae, because in the Hansen's disease, what do you get? You get the involvement of all the sensory nerves. So the trigeminal nerve is also affected. We have decreased corneal sensations along with the involvement of orbicularis oculi. So if you see the ocular manifestations in cases of the leprosy, all the actually organs of the eye are involved. We have involvement of the lids also. The involvement of lids are also there. The involvement of the lacrimal system is also there. We have involvement of the sclera. involvement of the sclera and even the cornea, then ciliary body, fundus, everything. We are getting the uveitis also, iris pearls also. So actually all the organs in the eye are involved, and we know that there is decreased sensations in the sensory nerves. So that is involving the cornea. Okay, that is why the answer to this question is Mycobacterium leprae, right? Okay, now this is a slightly different kind of a question, and there was a lot of controversy in the language of the question. Many of the students said that punched out lesions in the fundus are seen in, and many of the students said that it is seen in all except. Now, based on the options, I would say it should be seen in, because none of the other things are showing you the punched out lesions. Because if you see this, number one is the posterior staphyloma. So posterior staphyloma will definitely not give you the punched out lesions. What we mean by posterior staphyloma, it is actually the ectasia in the sclera. So we are having the protruded appearance, bunch of grape-like appearance. And where do you get this? In cases of the high myopia. In the cases of high myopia, we get this. So it's not a punched out lesion. Colopoma means there is an absence of tissue, right? So absence of tissue is also not the punched out lesion. Then we talk about the tuberous sclerosis. Tuberous sclerosis, again we are not getting any punched out lesion. It's a neurocutaneous syndrome or the phacomatous. Therefore, the answer to this question will be the toxoplasmosis. Therefore, answer to the question. See, punched out lesions is basically a word which is used for the patch of chorioretinitis. This is used mainly for the chorioretinitis scar. So, whenever you get such kind of a question, please see where you are getting posterior uveitis, where you are getting the chorioretinitis scar. According to that, you have to deal with this question. Here I have given you, this is a chart which is from the standard textbook Kansky and Yanov's. So they have given you a list of the diseases where you can see similar kind of lesions which are called as punched out lesions. So I think you can remember only the names of it. Like we have got the presumed ocular histoplasmosis syndrome. We will not go into the details because already it's a scope beyond, but because once this question had come, so if you want, if you wish, you can remember the names. One is the POHS. POHS means presumed ocular histoplasmosis syndrome. Okay. Second is the tuberculosis, but obvious. We have tuberculosis also, we have sarcoidosis, we have syphilis, all the granulomatous diseases are coming with the panuveitis, we have sympathetic ophthalmia, syphilis, sarcoidosis, and then there is a thing called as birdshot retinopathy. Birdshot retinopathy. Then other names, we have got the MEWDS. This is called as the multiple evanescent white dot syndrome. Then we have AMP, acute post multifocal placoid pigment epitheliopathy. Now, even if you do not know the full forms, not a problem, but because I am showing you, it's my duty to give you the full names also, but don't take a burden to remember their names. We have lymphomas, we have pneumocystis choroiditis, and the West fever. So basically, even if you do not remember the second list, please remember this one. Please remember this one. We have got the tuberculosis, we have sarcoidosis, we have syphilis, sympathetic ophthalmia, birdshot retinopathy, along with the toxoplasmosis. Most important causes of your punched out lesions, right? All right. Now coming to the next question, when the patient presents with a sudden painful diminution of vision. So I think this I have discussed so many times in the clinical case scenarios also, and in my videos, in my classroom teaching, that whenever you come have a patient with a sudden painful diminution of vision, always remember it's an acute red eye. And whenever we are having a patient of the acute red eye, either it is due to the acute congestive glaucoma or it is due to the acute anterior uveitis. Means 99% of the cases, it is always either of these. Now, so this acute anterior uveitis can be associated with other things. Like it can be associated with the chemical burns also. Okay. It can be associated with the bacterial keratitis also. Acute anterior uveitis can be associated. This can be associated with the chemical burns. Whenever we are having chemical burns, we can have acute anterior uveitis, or we can have the bacterial, especially bacterial corneal ulcers. If we are having the bacterial corneal ulcers, then also why it's C? No, it's not C. See, why you have hypopion? When I talk about hypopion in the bacterial ulcer, remember, few questions back we have discussed that there was a hypopion in the bacterial ulcer. That was the pus in anterior chamber. Pus means inflammation or not. So in bacterial ulcer, always we have acute anterior uveitis, for due to which we have hypopion. So basically, it's the conjunctivitis. Yes, it's the conjunctivitis. Always remember, whenever the patient is coming with the acute red eye, it is not hemorrhagic conjunctivitis. Hemorrhagic conjunctivitis is basically caused by the virus. It is the viral conjunctivitis. It is caused by the virus. So always remember it's D. So remember this flow chart, acute red eye. If it's acute red eye, that means it is acute congestive glaucoma or acute anterior uveitis. If it is acute anterior uveitis, it can be chemical burns or it can be bacterial corneal ulcer also. Okay. So no conjunctivitis will actually lead to the acute red eye. It can only simulate. Acha. Who will tell me the important causes of hemorrhagic conjunctivitis? Come on. Important causes of, I have already told you that it is most common by the virus. So which virus is actually responsible for this acute hemorrhagic conjunctivitis? So it is the pico-RNA virus family. Pico-RNA virus family, whole of the family is there. And apart from this, we also, especially which one? Especially is the enterovirus. Especially is the enterovirus type 70. Then we have adenovirus, and then we also have the pox virus. No, Rohit, most common is not the adenovirus. It is the pico-RNA virus family, especially the enterovirus type 70. Then we have the adenovirus, and then is the pox virus. So most common way, it's not adenovirus. Okay. All right. Coming to the next, which of the following is the primary action of superior oblique? Now this was again very important because always in my classes when we talk about the actions of the extraocular muscles, we always take the example of superior oblique, and they had given that question on superior oblique. So let us try to learn this flow chart, how to find out the actions of the extraocular muscles. So we have got simple steps. Okay. We have got simple steps to find out the actions of extraocular muscles. So step number 1, you have to see whether it's a rectus muscle or it's a oblique muscle. Whether it's a rectus muscle or it's a oblique muscle. Because if it is a rectus muscle, then primary action will be the elevation and the depression. While if it's a oblique muscle, then the primary action will be the adduction and the abduction. Then it is Then it is the intorsion and the extorsion. Then it is the intorsion and the extorsion. Because it's an oblique muscle, so rotatory movements will be your primary muscles. Now because here we are talking about the superior oblique, so primary action here will be the intorsion. Why I can say it's intorsion only? Why not extorsion? Because you know that superiors are intorters. Remember, sin means superior muscles are always intorters. And because we are talking about the superior oblique, therefore primary action will be intorsion. Now coming to the step number 2. Step number 2. The step number 2 says that once you have done with the primary action, so there will be interchange of the primary action. So if it was a rectus muscle or if it's a oblique muscle. If it is a rectus muscle, primary action was elevation, depression. So secondary action will be now intorsion and extorsion. And In oblique muscle, the primary action is intorsion and extorsion. So secondary action will be now elevation and depression. Okay. Now how to decide for intorsion, extorsion? Again by sense. Superiors are intorters, inferiors are extorters. How to decide for the secondary action? Because O for oblique and O for opposite. O for oblique, O for opposite. So if it's oblique muscle, it will go in opposite direction. So for superior oblique, secondary will be depression. And finally, step number 3. Step number 3 mein, what will happen? You have to see the rat. The third mnemonic is the rat. Means recti kya tertiary. For the recti, it is the adduction. And if it is oblique, it will be abduction. So tertiary action will be abduction. So you don't have to cram any of the actions. By this simple 3 steps, you can find out the actions of any of the extraocular muscle. Something like this. What is the primary action? Primary action will be intorsion. We are not told about that in the question. What you are not told about? We can see red eye in both in hemorrhagic and acute red eye. See, you will see the red eye in both, but there is whole lot of difference. I will show you that there is a whole lot of difference in the acute red eye of both the cases. Let me show you. There is a lot of difference. See, it opens at the right page. See this. This is acute hemorrhagic conjunctivitis. Can you see? This is the redness. Cornea is clear here. Okay. But when I talk about the acute red eye, it is a circumcorneal congestion. So circumcorneal congestion will be all around the limbus. If I show you that also, just a second. See this. This is your circumcorneal congestion, which is also called as the circumciliary congestion. You can see something like this, all around the limbus it is there. This is your circumciliary congestion or the circumcorneal congestion, which is your acute red eye. While in cases of the hemorrhagic conjunctivitis, it is pure redness only in the superficial one. This is the deeper inflammation, that is a superficial inflammation where you are going to get the diffuse arborizing pattern. All right. Okay, now coming to the next one. Now we come to the INSET November 2021. So let us see how many of you recognizes this. So let us do this fastest finger first. Identify this is just a spot diagnosis. And few days back, I had also posted this in the IBQ, in the Insta story. So this is very, very typical. The Vossius ring. No, it's not the KF ring. It's the Vossius ring. Vossius ring is found in the blunt trauma. This is found in the blunt trauma. And what is it? It is actually the imprint of the meiotic pupil. Imprint of the meiotic pupil on the anterior surface of the lens. On the anterior surface of the lens. Imprint of the meiotic pupil on the anterior surface of lens. This imprint is called as the Vossius ring. KF ring, where do you get? KF ring you get in cases of the Wilson's disease. The question had come also in NEET 2023. Fleischer's ring is found in the keratoconus. And Weiss ring, this is found in the fungal keratitis. Right? So Wilson's disease, KF ring is due to the copper deposition. Fraser's ring is due to the iron deposition. Exactly, Athar. Exact definition, very good. Okay. Now, who will tell this? Again, a single liner question. Which cerebral lobe controls the coordination of eye and hand movement? So this is the parietal lobe. I think it's not a tricky, a direct question. Now see this. What is this? Where is the lesion located which can cause a defect like this? So you can see that it is the temporal portion of this eye and the temporal portion. Now, even if you do not know which eye, but otherwise you should know which eye is this. Your right side will be the right eye visual field and your left side will be the left eye visual field. So you can see this is bitemporal. This is bitemporal hemianopia. Bitemporal hemianopia. Because it's a bitemporal hemianopia, therefore this is the lesion in the optic chiasma. So answer to this question is the optic chiasma. I think a very straightforward question, very important. This is other difficult, so they have asked actually NEET now. Right-sided vision defect in both the eyes, right homonymous hemianopia, right homonymous hemianopia with the macular sparing. So we have done even more and more complex questions related to this. Yes. Other options, image about ring. I could not get what you are trying to say. Please be more clear. Ye dekho, what is this? Identify the given image. What is this? Again, the question was only on the identification. This is actually the Hess chart. Now, I will show you the Hess chart. I will tell you what it is used for. But if you look at this, now, suppose you do not know what is Hess chart, but at least you know Snellen's chart. It is not Snellen's chart. It is not the ETDRS chart. Snellen's chart is used for the visual acuity. ETDRS chart is used for the diabetic retinopathy. Pelley-Robson chart. This is used for the contrast sensitivity. Yes, everybody recognizes this now. This is for the contrast sensitivity. So by again eliminating the other options, wrong options, you know, this is the Hess chart. So see, this is the Hess chart where we are putting the plots. We have a x-axis and a y-axis. So we have the ocular position as a function of the extraocular muscle action. Position of the muscle and the action of the muscle. Like this it is plotted. Okay. While on the other hand, we have got one more chart which is also has a slightly different principle, but it is used for the same purpose to find out the palsy in cases of the paralytic squint. This is called as the Lee's screen chart. So once they have asked you Hess screen chart, you should also know that there is a Lee's screen chart also, and both of these charts are based on the dissociation, but the method of dissociation is different in both. Okay, so this one is your Lee's screen chart, and the one-sided one, this one is your Hess screen chart. Also remember, right? Then coming to the next question, see, I told you one of the questions is always on the steps of the cataract surgery. So can you identify what is the step of this cataract surgery? They are trying to create the opening in the capsule, because they are trying to create an opening in the capsule. Therefore, this will be called as the capsulorhexis. Therefore, this is called as the capsulorhexis. Now, what are the two types of capsulorhexis? What is the dye which is used? All these things can be used. So, we know that capsulorhexis can be of the two types. It can be circular, curvilinear capsulorhexis, or second one, it can be the can opener. It can be a can opener technique, and the dye that we are using is the trypan blue. The dye that we are using here is a trypan blue dye, right? Okay, now coming to the next question. This is a question of ophtha plus medicine. You can see here that 14 days old neonate is developing conjunctivitis. So what is coming to your mind? We are thinking about the ophthalmia neonatorum, right? So therefore, we are talking about the ophthalmia neonatorum because neonate means less than 28 days and this child is 14 days. So that means we are talking about ophthalmia neonatorum. Now, when we talk about the cause, you have to see less than 48 hours or you have to see more than 48 hours. Okay. So less than 48 hours may it is gonococcal. It is gonococcal. So this cannot be case. After 48 hours, the most common is always the chlamydia. Most common is the chlamydial. Therefore, the answer to this question will be the chlamydia trachomatis. Now, apart from this, you have also learned that there are bilateral infiltrates, we have pneumonitis, lymphocytic predominance. So, we can confirm this from our micro as well as medicine knowledge. This can be a question of pediatrics also, it's a neonate, and of course conjunctivitis also, so ophthalm. So it is a chlamydia trachomatis. Most severe is the gonococcal. So if you talk about most severe is the gonococcal while most common is the chlamydia. Alright, next question, which of the following antidepressant should be avoided in the acute angle closure glaucoma? So this kind of a question has been repeated so many times and I had kept this question in your TNDs also. If you remember that many a times you are treating any other condition but basically this patient can go into acute congestive glaucoma. Like one such kind of a drug is also the tricyclic antidepressants. Tricyclic antidepressants, amitriptyline can also precipitate. So please remember this whole list. Many drugs are there which can be associated with the angle closure glaucoma. One will be your sulfur derivatives. Sulfur derivatives may like topiramate also. This is also a PYQ of AIMS. Topiramate can also cause the angle closure glaucoma. In the anticholinergics, we are having this tricyclic antidepressants. We are also having the selective serotonin reuptake inhibitors. I think both of them are important. They have been asked. Adrenergics we already know. Anticoagulants we already know. But these two are very, very important. Topiramate pe there have been a question many times. The bilateral secondary angle closure glaucoma can occur and even the antipsychotics, antidepressants, benzodiazepines, all these can also cause the angle closure glaucoma. So you can learn most of these things. This is your ophthalmology plus pharma. So whenever you get some ocular complications, some ocular side effects in your drugs, that always become important, especially for the Inset. They are always asking you the ocular side effect of the systemic drugs. Which one of the following is the most common ocular manifestation of the COVID-19? So this we have already discussed. Most common is the follicular conjunctivitis, right? Then coming to the Inset July 2021. So now this was one of the controversial questions and I think you will remember and relate that I always tell this thing in the classes also, that once this question came, when they are talking about the route of spread of the retinoblastoma, and this is a very well-known thing. We all know that it's a direct route by the optic nerve, but what if they give you both? So in this, they had given you both direct spread also and optic nerve also. In that case, you have to choose the optic nerve without a doubt. Okay, so don't do this mistake of putting the tick over the direct spread. No. So always remember, in those cases, you don't have to go with the direct spread, you have to go with the optic nerve invasion. If both are given, always go with the optic nerve invasion, right? Now see this question. There is a proctosis in a child. This is ophtha plus patho. Proctosis hai along with a Desmin positive tumor. Now there are two things. First of all, if I am talking about proctosis in a child, and they have already admitted that it's a tumor. Now, which tumor is most common in the children? So, if I talk about the tumors, okay, remember the flow chart that it can be the primary tumors, it can be the secondary tumors, and it is the secondary tumors which are actually more common in the eye. Now, good evening. Now, if they talk about primary tumors, then it can be the intraorbital tumors also, or it can be intraocular, right? Now, because they are saying Desmin positive, that means it's not intraocular, but let's discuss both. So, this can further be divided into the adults or childhood. This also in adults or in the childhood. So, if I talk about intraorbital in adults, it is the cavernous. It is the cavernous hemangioma. And intraorbital in children, it is the rhabdomyosarcoma, right? So it's a myo, because Desmin positive means it is related to the muscle. So most probably it's a rhabdomyosarcoma. Intraocular in adults is a malignant melanoma, and intraocular in children is the retinoblastoma. Now retinoblastoma is coming from the blast cells of the retina, so this cannot be the answer. So we are thinking in terms of rhabdomyosarcoma, and it's a Desmin positive also. So therefore there is no confusion that the answer will be the rhabdomyosarcoma. Now one more thing, whenever you are having a rapidly progressive, supranasal mass in a child. Okay, suppose you are having a rapidly progressive supranasal mass in a child, then you have to consider it as a rhabdomyosarcoma unless proved otherwise. A very, very important dictum. Unless proved otherwise, you have to consider it as a case of rhabdomyosarcoma only. So this will again help you in solving the question so many times. Why we had considered this as a rhabdomyosarcoma only, why we have not thought about retinoblastoma, because this has to be considered always as a rhabdomyosarcoma unless proved otherwise. Okay. Now who will tell this? Identify the site of lesion. So we can easily identify the site of lesion once we know the type of lesion. This will be the right eye field, my right side. This will be the left eye field, my left side. So this is the right side of the right eye. This is the right side of the left eye, right? So this is right homonymous. Therefore, again, I will not require even pen and paper for this. I can say it's a right homonymous hemianopia. Right homonymous hemianopia. But what is this, guys? You can see there is a sparing in the center. So this is called as the macular sparing. And why do we have the macular sparing? What does macula have in special that it is spared? Due to the double blood supply. Due to the double blood supply. Due to the double blood supply, we also have the macular sparing. So where do you get this macular sparing? Where do you get this macular sparing? We get this in the occipital lobe. So it is in the occipital lobe. Optic chiasma mein we get the bitemporal. This we have already discussed. Here you will get the bitemporal. So optic chiasma is not the answer. Lateral geniculate body mein no macular sparing. So this is also not the answer. So answer is occipital lobe. Now right or left? So always remember that it is contralateral homonymous hemianopia. It's always contralateral. Now because it is contralateral and they are telling you right homonymous, therefore the answer will be in the left occipital lobe. So basically you can do it orally. You can see, oh, right side of both the eyes getting affected with the macular sparing. So macular sparing means occipital lobe and right side lesion, therefore left side defect, right? And vice versa. So if you are getting the right homonymous hemianopia, defect is in the left occipital lobe. This is how you have to do it. I hope it's clear. Most common lacrimal gland tumor. Now again, to be very, very specific, if they ask you about the lacrimal gland tumor, most common is pleomorphic adenoma if they are asking you about the benign. And if they are asking about the malignant, it is the adenoid cystic carcinoma. All over, I can say, see, benign tumors are always more common than the malignant tumor. So all over, most common will be your pleomorphic, all over, most common will be the pleomorphic adenoma. And if they ask you specifically the most common malignant, then your answer will be adenoid cystic carcinoma. Yes, everybody is giving the right answer. Very good. So pleomorphic adenoma will be the answer here. If they do not mention benign or malignant, you have to go with the benign one. Now see this, how to do this kind of a question. Now whenever you get this kind of a question, you don't have to see all the 9 images. First see the central image, this primary position you have to see. Now what you can see here, I'll use the black color over it. You can see something here. What is this? This is the ptosis. You can see the ptosis. Ptosis is due to LPS muscle. LPS is supplied by third nerve. LPS is supplied by third nerve. Then what else can you see? When we are everting this eyelid. When I am everting this eyelid, can you see the eye is down and out? It is down and out. Now these two things are sufficient to say that it is a case of the oculomotor nerve palsy. Okay, so don't struggle, don't get into dilemma, don't panic, don't waste your time in looking at every image. Just see that you can see the ptosis, and when they are everting, their eye is down and out. Why? Because what happens in the third nerve palsy? So let us discuss the third nerve palsy also. So all the muscles will get paralyzed except the SO4 and the LR6, because you know third nerve supplies all the muscles except for the superior oblique and the lateral rectus. So all the muscles will get paralyzed except for these two muscles. Now just now we had done the actions of superior oblique. It was intorsion, then depression, and then it was abduction. Lateral rectus is also abduction. So basically abduction is spared in both. Therefore, this action will be spared maximally. This action is spared maximally, and the eye will be depressed and abducted. So we can say that the eye will be in down and out position. It will be in the down and out position, right? Third nerve palsy, very, very important. Okay, now see, yes, I told you, trachoma is again important. Safe strategy for the trachoma, who will tell this? Surgery for the trichiasis is okay. S for surgery, A for antibiotics, F for facial cleanliness, and E for environmental hygiene. So answer will be evaluation of the program. This is the environmental. This is the environmental hygiene. Therefore, the answer is, why it's B? It's D. I think it's typo error. So it's D. Evaluation of a program nahi hai. It's the environmental hygiene. Safe strategy for the trachoma, right? Finally, we come to the INSET November 2020. So our favorite KF ring. Which of the following are true statements about the KF ring? Number 1. So you will tell me true or false for each statement, and then we will go for the right answer. Seen in all patients with neurological involvement, it is about 90 to 95% that we get the involvement. Is it pathognomic for Wilson's disease? No, because it is also present in the primary biliary cirrhosis. Okay, so you cannot say that it is pathognomic. Pathognomic means it will not be found anywhere else. Resolves with the treatment? Yes, because it is reversible. So yes, we can say it is resolving. Seen in all patients with hepatic involvement? No, 50 to 55% of the hepatic involvement. And first seen in superior inferior quadrant, like this and like this. This is again true. So can you tell me what are the true statements now? What are the true statement? I can say true statement seen in all patients with neurological involvement. I can take because 90 to 95% people are there. It's not pathognomic. So this is not true. Resolves with the treatment. This is also true. Seen in all patients with hepatic involvement. No, because 50 to 55%. And seen in the first in the superior inferior quadrant. So it is 1, 3 and 4. So I think none of the choices are right here. Maybe they have given something wrong here. But it is actually 1, 3. 1, 3 and 5. So we can make this one as 1, 3 and 5. And then A will be the answer. It is actually 1, 3 and 5. These are the choices which are correct. Okay. So these choices can be here and there. But the thing is that you should know the concept and the right things. Alright. Now see another question. iritis is seen in. Iritis. Acha, from your side, we have read something called as acute anterior uveitis along with the arthritis. This we have read so many times, right? So how many places you know that we can have the iritis or iridocyclitis in the acute anterior uveitis along with the arthritis? I can have the ankylosing spondylitis. I can have the Ritter's. Ritter's can be there. We can have psoriatic arthritis. Psoriatic can be there. We can have inflammatory bowel disease, and then we can have the juvenile rheumatoid arthritis. So how can you say it is not rheumatoid arthritis? So psoriasis may you can have, ulcerative colitis may you can have, Behçet's disease may you can have the triad, that you can have here also. Then what about now the people who are saying that iritis is seen in rheumatoid arthritis? Why not Behçet's disease? Behçet's disease may we get the uveitis along with the oral ulcers, along with the genital ulcers. We get psoriatic arthritis also. Now there is a, see, I have taken out the printout also from the Parsons. This is why, you know, textbook reading is sometimes important, and I insist to go through the Parsons series also. Now see this. If you look at the, this is the last chapter of the Parsons, where they have given you the ocular manifestations of the systemic disease. They have given you rheumatoid arthritis and SLE, giving you iridocyclitis and iritis. So basically we can have in rheumatoid arthritis also and SLE also. Therefore the answer is all. In all the places you can have the iritis or the iridocyclitis. Please see this. So iritis can be seen in all of the places: rheumatoid arthritis, Behçet's disease, ulcerative colitis, then SLE and psoriatic arthritis. Refer to this flow chart. This is in the Parsons last of the chapter. You have this flow chart. Okay. Next question. What is true regarding the open angle glaucoma? Now, I know most of the students have confusion in option number 1. Why, ma'am, this is wrong? Now, see, they are saying abnormality of the trabecular meshwork. Is it a abnormality of the trabecular meshwork that is seen, or blockade seen? There is a difference between the abnormality and the blockade. In the open angle glaucoma, you are going to get trabecular meshwork block. You are not going to get the abnormality. Abnormality is actually seen in the angle closure glaucoma. So this is actually false. First degree relatives have more chances of developing steroid induced glaucoma. Yes, this is true, because always we have the hereditary or the genetic predisposition that is there. Dilatation of the pupil is associated with exacerbation of IOP. Can you tell me, is it true or false? Will the dilatation of the pupil cause open angle glaucoma? No, it's a false statement, because the dilatation is associated again with the angle closure glaucoma. First degree relatives are at 1% risk. Now this is also wrong. They are about 10 to 15% higher risk in the first degree relatives. So this statement is also false. And visual field defect can exist with a normal CD ratio. Now this is true. Why? Because we can have normal tension glaucoma. If a patient is having normal tension glaucoma, any two out of the raised intraocular pressure, we have the optic disc changes, and then we have the visual field effects. Any two. So even with the normal CD ratio, means I am not getting optic disc changes, but I can have raised intraocular pressure and the visual field effects. Statement is true, and the first degree relatives have more chances of developing the steroid induced glaucoma. That is also true. Therefore the answer will be 2 and 5 only. Okay, don't get confused by the abnormality of trabecular meshwork. That is not the abnormality. Abnormality means you are having some congenital malformations that is seen in the angle closure glaucoma. All right. Now, last but not the least, how to differentiate the causes of the dilated pupil. Now, this question, again, there was some problem, because I think two options came same. 1% phenyl, they had given 2 times 1% pilocarpine. So I think they have changed it to 1% phenylephrine and 1% pilocarpine, 0.25% pilocarpine. 4% cocaine and epinephrine. Now, nevertheless, actually this question is actually based on a flow chart of the anisocoria. Very, very important, and please remember this flow chart for your INSET examination. So when I say it's anisocoria, that means there is a difference in the size of the pupils. Difference in the size of the pupils, if it is more than 0.4, then that is called as the anisocoria. Now, whenever you are getting something like this, you have to see whether it is increasing in the dark or whether it is increasing in the light. Whether it is increasing in the dark or increasing in the light. If it is increasing in the dark, then this is your Horner syndrome. This is again a AIMS question, and before this INSET 2020, the August 2020 paper which occurred and with the name of the AIMS only. This is the AIMS August 2020 paper. We got this. Okay. Now, if it is increasing in the light, okay, if it is increasing in the light, then you have to first see the shape of the pupil. Then look at the shape of the pupil. It can be normal or it can be abnormal. If it is abnormal, that means it's a case of trauma. So we can even diagnose a case of sphincter damage or sphincter tear. And if it is normal, then you can start with 0.125% of pilocarpine. So basically it's not 0.1, it's not 0.25, it's 0.125. This is actually the dilute pilocarpine. And then you have to see whether the constriction is present or it is absent. So there is only one kind of a pupil which is showing you the constriction here. If you talk about the constriction, right? So 0.125% of pilocarpine, and if it is positive, then you get only one thing, that is your Ades tonic pupil. Ades tonic pupil. Now, if it does not get, then what we can do? Then we can give the 1% pilocarpine. Now I can give the 1%. So 0.125 is also used, and 1% is also used, and now you have to check whether it is constricting or whether it is not constricting. If it is constricting now, then it's a third nerve palsy. That means it's a third nerve palsy. But if it is negative, that means it's a pharmacological blockade. That means it's a pharmacological blockade. So basically, third nerve palsy, pharmacological blockade, Ades tonic pupil. Then we have the trauma, and then we have the Horner syndrome. Now, how can you confirm the Horner syndrome? We can confirm by the cocaine test. It's the 4% cocaine. So further diagnosis of the Horner syndrome can be made by the cocaine, or it can be the 1% epreclonidine. We can use any of them, though 1% epreclonidine is usually preferred. Because why? Because it is not substance abusive, and plus it is giving you the positive result in cases of Horner syndrome. And then further it can be divided into the pre-ganglionic and the post-ganglionic. We can also divide into pre-ganglionic and post-ganglionic. For this, we use the amphetamine test. For this, we are using the amphetamine test. So please remember all these tests. Please remember the full flow chart, the definition of anisocoria, then which anisocoria increases in dark, which anisocoria is increasing in the light condition. So according to that, you have to choose the options. And I think there is a lot of problem in these options. 1% phenylephrine is okay, and 4% cocaine is okay. But I have doubt about this. Pilocarpine is obviously not used. Sorry. Phenylephrine is not used. It is a 1% pilocarpine that is used. And I think one is missing here. It is 0.125% pilocarpine that is used. So phenylephrine is also not used. Epinephrine is also not used. So the options should be the 2, 3 and 4. So answer will be D here. So basically, again, I am telling you because it is based on the recall memory. So one or two option can be here and there. But our idea is to tell you what are the important topics and to give you the concept behind that topic, so that even if they are asking you the repeat question with a slightly twisting or slight tilting, you can answer it because you know the concept behind it. Don't just mug up the answer. Okay, so please look at these things. These are all the questions of the INSET. I hope you have understood, and in case of any doubt, you can follow us on all the social media handles, and we will be more than happy to answer your doubts. Right, guys? So take care and all the best. Take care. Happy ophthalmology. Bye-bye.